We want to welcome today Lisa Smithgall. Dr. Lisa Smithgall is a PhD nurse who leads the Ballot Healthcare Initiative for nursing, and she's one of our own, a graduate of East Tennessee State University with her PhD in 2010. I will tell you that Dr. Smithgall serves as the Senior Vice President and Chief Nurse Executive at Ballot Health, and also she's adjunct faculty and co-coordinator of the East Tennessee State University Holston Valley Medical Center Accelerated BSN program in Kingsport. And there are many things I could tell you, but she is certified in neonatal intensive care nursing and also a certified pediatric nurse practitioner. And Lisa, welcome to our group.
Well, great. Thanks, everyone. I appreciate the time this afternoon. And I will do a pretty brief presentation, but I wanted to share with you some of the catalysts that are impacting healthcare at the hospital level and why we do some of the things we do and how we look at some quality projects to meet the goals of some of the pressure we have externally, potentially from regulatory bodies and or financial pressure. So, what I thought I would do is really briefly just go through value-based purchasing, because that does really impact a lot of things that we're doing in the hospital setting, and a couple caveats ahead of time. Ideally, healthcare would have taken the evidence and the literature as it comes out and implemented those practices in hospitals, that we would have the best practice. But sometimes, that doesn't work that way. And you need regulatory people to enforce those things to make that change happen, because people just keep going along as they're going and they're not considering those new things. And also to let you know, I know that you are aware of this probably, but that healthcare is, in the United States is one of the most expensive healthcare systems in the world. And hospitals get most of their reimbursement, greater than 50%, from the Medicare program. A lot of elderly use a lot of healthcare, and that's the major funding source for many hospitals. And on top of that, then you have the Medicaid population, which is also a governmental payer, which is pretty expensive for the government in general. So they have implemented, starting back in about 2011, with increasing pressures on healthcare, they started with a pay-for-performance kind of practice where they said, we have this DRG model where we pay for pneumonia or pay for a gallbladder surgery or whatever we pay for, but if you have a complication that's an adverse event, we're not going to pay you for that. And that was kind of the premise of the pay for performance. In value-based purchasing, they developed a different kind of strategy where they're going to take Medicare funding and they want to incentivize hospitals to really do the best possible job for quality that you can in taking care of patients. So that started in 2011. And the difference or the issue is here that even though 35% or more of the patients that are paid for your services are paid for by commercial insurance, once they saw what the governmental payers were doing, they also wanted in on that kind of activity because they want to preserve their dollars they're paying as well. The really key parts of healthcare reimbursement from the hospital level is that even though the largest percentage are governmental payers, generally the governmental payers don't pay you what it costs you to provide the service. For example, in a Medicare model, if it costs $1 to care for a patient with supplies and electricity for your building, those kind of things, they pay anywhere close to 90-something cents for that reimbursement. So you're not making as much money as it's costing tentatively. And Medicaid, as a rule, is much less, often 69 cents to 70-something on the dollar. So it is pretty significant that we have to do things as cost effectively as possible, but also because we need to preserve our reimbursement, we have to follow these value-based purchasing models now that are now in place. So the Social Security Act put this in place, and it's administered by the Centers for Medicare and Medicaid, which is CMS. And it's delivered this. They're wanting that healthcare to be delivery to be incentivized based on the quality of the care delivered and not necessarily how much quantity of care. So it doesn't matter what the patient's using when they're in the hospital, they're working on what's the best outcome for the patient, and they're going to incentivize people for that. And they do that through an inpatient prospective payment system. It's got a lot of points and ways that they evaluate that on how they're going to reimburse hospitals. So the goal of these programs, the reason they did this is that they want the quality of care to be better for patients in the hospital. And they want the patients to also have a better experience, like a customer service experience while they're in the hospital. So the overall actions that they want to accomplish are that they're eliminating and reducing the occurrence of adverse events. You're aware that there are a lot of errors potentially in hospitals that can cause harm. They want to reduce that. They want hospitals as a whole to adopt evidence-based care standards and protocols so that you're doing the best things for patients that the evidence has supported and said that if you do this therapy or this treatment or this medicine, this is going to be the best outcome for the patient. And they want to make sure that hospitals are doing that so that the patients have lower length of stays and all of the things that they need to get as healthy as possible and get out of the most expensive treatment regimen as quickly as possible. So again, they want to incentivize hospitals for the patient experience. They want to have transparency for the consumers. That's why all this data is now publicly reported. And they want to recognize with higher incentives those hospital systems or individual hospitals that deliver the best cost or the best quality at the lowest cost. So what they've done is they say if this is a reimbursement from Medicare DRG, they've withheld 2% of every potential reimbursement of those different DRGs. They put that in a bucket and they save that money, and they're going to use the hospital's performance to reimburse that pot of money to all hospitals in the country that are participating. And excuse me, they have a system to do that, which I'll quickly explain, and there's no test, but I'll certainly share these slides so that you have them in case you want to have that later. But they're based on a bunch of different measures, and that's how they use the reimbursement strategy based on the measures and the way that hospitals perform on these specific measures. They include mortality and complications for some specific diseases, if a healthcare associated infection occurs in the hospital, patient safety events, patient experience, and again, that efficiency and cost reduction strategy. So hospitals get rated on whether they have achievement of the objective at a certain level of threshold or benchmark, and also they get points for improvement. So if they didn't do so well in previous years and now they're doing better, they can potentially get better points and potentially have more incentive awarded. So they are being compared not only to how do the hospitals perform against other hospitals, but also how they perform against their previous practice in a baseline period. So specifically, the year we're in right now and how the hospitals are getting reimbursed at Ballad Health are in the 2021 Hospital Value-Based Purchasing Program. And it's based on all of our reimbursement in this year. And the fiscal year for the federal government is October 1st through September 30th each year. So it started last October, so we're getting a certain percentage of reimbursement that is based on a previous evaluation of baseline and our data, which I'll show you where we're being evaluated right now. So when they take that 2% bucket of money, if you do really, really well, you might get the 2% that was held back, plus an incentive because you did better than other hospitals. You might not get the entire 2%. You might get a very low number, so you could get less than the reduction, or you might get exactly the same amount and get the 2% with no change. So it just depends on how you perform. And currently, there are 4 buckets or domains that make up the score that they rate you on to see what your percentage score will be. The clinical outcomes, there are 3 mortality measures and a surgical complication measure. In the engagement, this is pretty much the HCAHPS that you might have heard of, which are the patient experience survey results, and you have to do that through a national vendor. We use Press Ganey at Ballad Health, and they're very specific questions that you have to get certain scores on to meet that metric. In the safety domain, there are 5 healthcare associated infection measures. And then in the efficiency and cost reduction, it's based on your spending of Medicare spending, and it includes several different caveats as well. And you can meet 3 of the 4 and still get incentive, but you have to have at least 3 to hit those. And I don't know where your pictures are. Mine are kind of off to the right covering some of this, but these are the 4 domains on the left. And then these are the specific things that we're being rated on. And you can see that for example, in the clinical outcomes, they're based on the mortality rate of people with MI, with obstructive pulmonary disease, heart failure, if they have pneumonia, or if they have complications for hip and knee surgery. The critical thing here is we have to then control not just what happens in the hospital, but how does the patient do outside of the hospital. So we want to make sure we have really good planning, because discharge planning, it can come back and it can either harm us or not based on our score on these. Generally, for example, the hip and knee complications, that can be really serious. We know that they do a lot of hip and knees in surgery centers, but the patients in the hospitals are maybe more at risk for complications. So we have a lot of challenge as well to prevent complications in those patients that we have. Specifically looking at the customer satisfaction, it's really about what was that patient's perception of the experience and the communication and the responsiveness, those kind of things, about how do they about their communication about medications, and do they know how to use those, and the goal being to prevent some readmission within 30 days. You want to avoid those as much as possible. The safety, CLABSI, CAUTI, those are the central line associated bloodstream infections, catheter associated urinary tract infections, all the things that we never want people to get anyway when they're in the hospital. And we should have always been working really diligently to prevent. But unfortunately, we probably didn't do the best job that we could, and we had to have this kind of, insight into, you have to get this done or lose your money, to get good practice placed in the care of our patients. So again, these are some things we're looking at and we get scored on. There is a baseline period of time where they say at the beginning, this is what your data is that we're going to look at as the baseline. And then there's a performance period where today's rates are being evaluated on specific actual results of how did we do against those measures in the previous slide. And we either get achievement or improvement points. And the critical piece here is that we're collecting data on all patients, not just on Medicare patients. So therefore, if we have a deduction, it affects entire patients in the Medicare population, even if only a few of them were impacted. So it's really critical that we try to have 0 events related to certain things so that we can get as much of our incentive as possible. So specifically here, you can see that we're being reimbursed today in 2021 for the care we're delivering, but you can see that the patient performance data, and I have to just move the people here on my slide, are, for example, the mortality measures, we're being paid in 2021 on the way the mortality measures were captured upwards of 2016 to 2019. And so we're being evaluated and paid today based on how we performed several years ago. So it's really impressive that you are impressed upon all of us that we need to improve continually, because anything we're doing today is going to impact us for years to come, because this program has been in place for a good 10 years, and I don't anticipate that it's going to go away anytime soon. All right. So this is just another example of how you can do it, and the wording or the point adjustment, which you don't really need to understand that, but just so you can see that you get different points based on how you do, because you look at your hospital and how does it perform against all hospitals. You have to at least hit the basic, the benchmark and the threshold. If you don't hit the threshold, you're not eligible for any points. But as long as you have a score that is about the threshold, and they do that based on certain hospital performance, then you get points above that. So there are hospitals that don't hit the threshold that aren't eligible for any points at all. And then this is the way they look at you personally. They say, how did you do in the past? And are you at least improving? And how much have you improved? And based on how you improve from previous scores or previous surveys each year, they do this evaluation annually, you may get more points, and therefore then you would get more potential reimbursement. And the other important fact here, and I'm sure you know it, is as our hospital system is really working to improve, so aren't all other hospitals in the nation as well. So these targets are continually moving. So I wanted to just quickly talk to you about how did we address one issue at Ballad Health to try to improve this activity so that we can have, one, better outcomes for our patients and really reduce our CAUTI. And I'm going to talk to you about some stuff that we did at Holston Valley. And I presented this in 2018, so it's a little bit older, but it just is a perfect example of what we did to try to use the evidence, use the quality, and try to improve our responsiveness to the requested actions. And you can see based on our the scoring and payments we're doing in 2021, this is the data that was now affecting us as we are being reimbursed for the work we did there. So in 2012, the required reporting went into place for catheter-associated urinary tract infection. And even though that was required and we started reporting it, much like anything, we weren't being penalized for it yet in 2012. They were just starting to look at that. It was mandatory reporting. And as a result, we just were reporting it. We didn't really have a lot of changes in our practice. And then the value-based purchasing information came into play, and we knew that it was going to be impacting reimbursement. And unfortunately, that's the thing that raises everyone's attention and says, okay, we need to really work at this, and we need to start looking at ways that we can reduce CAUTI in the hospital. So in October of 2014, a system-wide CAUTI committee was implemented. Of course, this was in the legacy Wellmont system. But again, even though there was a system-wide committee, there was a lot of activity that was going on, but we still didn't have a lot of change at Holston Valley. So in January of 2015, they did increase the reporting requirements for the addition of medical surgical CAUTI occurrences in NHSN, which is the national reporting area that you have to report your results to. And that was when a lot of cadence really came into play, and we really needed to move and get our acts together, because we were now going to be starting to be really penalized if we didn't have improvement. So they also removed yeast as a qualifying infection, because during this whole pre-period where they're evaluating all the infections, they knew they were looking at what truly should the metric be. So in April of 2015, we really kicked in a lot of activities, and we started to work on this project with goals of, one, improving our urinary catheter management and reducing our urinary catheter days. So we reduced, and our goal overall to reduce the incident of CAUTI for every patient in every unit of the hospital. And we worked really diligently, and we had a multifaceted action plan, and we had executive support. We developed protocols based on the evidence. We did a lot of research. We worked at developing some standard work, and we did a lot of re-education and education for our staff. And we initiated a hospital-acquired infection committee because we wanted to review this really critically anytime we had an infection, so we could identify any trends that were occurring so that we could really drill into this and maybe fix something. And what we found is, I'm sure you can imagine, that after years of having nurses who were delivering, initiating catheters, urinary catheters, sometimes the practice wasn't the best practice. And these would be orienting new nurses and teaching the way they do it. And it wasn't necessarily the best practice that we had in place, is what we found. So in the fall of 14, they had developed a protocol, and it was based on the evidence-based review of the literature and the practice, benchmark practice from other hospitals, and it was built into the EPIC EMR. That in February of 15, that protocol went live. It was a nurse-driven protocol, and the intent was that nurses would be able to only implement urinary catheterization in certain situations. We didn't automatically do it, but that we had specific indications of when that would happen. And also we had a catheter removal protocol, because our goal being, as soon as that patient didn't need it, we wanted nurses to get that out as soon as it was possible. We didn't want to have to wait for an order and do that. So we had a protocol that the physicians could order. So it was placed in the EHR. And when the physician ordered that, the nurse-driven protocol, the nurse would pull that protocol into the charting record. The problem was that even though it was out there, physicians didn't automatically check it, and we didn't have great results with that. Even though we knew it was the best thing, we had a multidisciplinary team, they probably knew it was the best thing, but we just didn't have the greatest results with that. So in the fall of 2015, we asked for that to be an automatic check every time a urinary catheter was ordered to be placed, and that the physician had to uncheck it if he didn't want the nurses to automatically pull it when the criteria wasn't met. And that obviously had significant improvement in our result, and nurses had the authority to just pull that catheter when the specific indication wasn't present. But as I'm sure you can imagine, some nurses were still a little hesitant to do that, but we worked very diligently to do that. This was the very complicated protocol, which I won't go over there, but you can see on this urinary catheter removal protocol that there were very specific criteria in the lower right-hand corner of if these were no longer met, that the nurse was supposed to just remove the catheter as soon as it was no longer needed. So in 2015, we also re-educated all nurses. And as I said a little bit earlier, we identified that some of the practice wasn't the best. And what we actually did, in addition to making them watch the computer-based learning modules, we actually had a skills lab with every nurse who had to come in, regardless of her years of experience, from new graduate through 25, 30 years, and they had to demonstrate appropriate technique and insertion of a urinary catheter. In addition to that, we did that for all of our, at the time, PCTs, which are our unlicensed CNA team members, and they had to physically demonstrate appropriate peri-care and care of the urinary catheter. So we actually were able to correct a lot of perhaps practice that wasn't optimal and really improve the appropriate delivery of that kind of care. So we walked and we did that. And then we also developed, working with a different vendor, a step-by-step urinary catheterization kit that we piloted to see. And at each step of opening the package, it tells you what to do, and it shows you the next step. And the next product became evident as you lifted up the paper in different parts. So you did it in the right step and you did everything appropriately. So that helped us as well. We developed that committee, and it was a multidisciplinary committee, and anytime we had any infection of those multiple infections that we talked about, CLABSI, CAUTI, or also VAP, the nurse manager came and they had to have done the drill down, and they talked about what was wrong, and they identified any trends they could find. We did it monthly. We looked at each one, and actually we invited our actual staff nurses as well to participate in this process, because we knew that reinforcement of the best practice at the front line was going to be what was effective in helping us to really improve the care of our patients and to have the best outcomes. So we knew we needed to involve the front line. So each group of CAUTI assessment was taken to the individual unit, and they all looked at that. They talked about it in huddles. They looked at the findings. If they found an error, they found an issue with the way practice was delivered in that unit. And it became a very competitive action because nobody wanted to have any CAUTIs. We did identify that our emergency department, where you enter the emergency department, you get a catheter apparently. We needed to do a lot of more re-education there as well. And we actually had to repeat the re-education in the emergency department with our RNs and PCTs again, after we had identified a continuing trend of non-compliance to our practice expectations. We developed a letter as well that we gave to each of our staff members and said, you know, if they had a patient, that if they were one of the care providers in the immediate period before this patient received or was identified as having a CAUTI, they got this letter, and we asked them to please, you know, review and their care and help us. And we reiterated, can they help us identify anything that might have contributed to this CAUTI? The reason being that we felt that any interaction right back to the people that were involved was really important, because what happens often is that the nurse may have cared for the patient 3 days before the CAUTI was identified, and they didn't know that that patient ever got a CAUTI. They just didn't have that connection, because till the patient was identified and then treated, they may not take care of them or may not know it. And no nurse wants to be responsible for contributing to a patient getting a hospital-acquired infection. So that was really helpful for us of raising awareness as well with our team. And every day on every unit, there was the daily review. Who has a catheter? Does it meet the criteria? If they don't, let's get it out. We had a lot of learning opportunities. This is just the letter, I won't read that to you, that all of our nurses got. And we just, in each of the things, we asked them to look at all the components of urinary catheterization, insertion, and care to just help them review and just reinforce what the expectations were. And can you help us identify anything that we might have had a problem with? Well, our results were great. We were pretty excited about it. We had significant improvement year over year. We had our greatest improvement in medical, surgical, and cardiac units. The nurses really adopted it. They were really methodical as well. They would not accept an ED patient for admission who had a catheter and didn't have an order. And if they had a catheter without an order and they didn't meet the indication, they asked them to remove that catheter before taking the patient to the floor. They also did the same thing with critical care and asked them to remove the catheter if it no longer was needed, because we found, just like the ED, that a lot of our intensive care patients ended up with catheters we perceived per convenience sometimes. So we just knew that that was something that had to happen. And we also wanted to make sure that we focused on our critical care units, because that was an area where we did not have the most success compared to what we had in our med-surg year of, or med-surg performance. So you can see that in 2012, and again, this was the initial reporting started, but wasn't fiscally implicated in any way, we had about 73 CAUTIs in the hospital in that calendar year. The next year, because we knew that was being monitored for whatever reason, I'm not sure, it pretty stayed about 62, not a great improvement, and similar in 2014. But when we started all the work in December, or January through December of 2015, we went to 22. In 2016, we went to 11 hospital-wide for the whole year. And then in January to December of 2017, we had 4. And we ended up in 2018 with a total of 8, but still significant improvement over time with this process. And this is just an example of the graph. And on that graph, you can see all those things I talked about where we implemented them. And we went many months with just 1 or 2. And this is an example of what is called the urinary catheter standard utilization ratio. And what that means is that's the number of predicted catheters that you would have in the population of your patients based on what's wrong. And you can see that that's at 1. So you can see that we were really pretty significantly in all of our units in 2015 when we started well over the ratio, meaning that we were using catheters more than would have been expected in our population. But as we really did this work over time, we are using catheters less than what they would anticipate for that volume of patients in the kind. So I'll just briefly run through these, but you can see that these are the individual units. This is the med-surg population, and the green bar just is the trauma population where they tended to have more catheter usage. These are our cardiac units, and the ICUs tend to be closer to the 1. They did have a little bit of improvement, but they all tended to be much higher in the usage. This is the, again, just the pictorial kind of graph going down. And it's important to remember that in the beginning of 2015, that was where they took yeast out. So yeast was potentially in some of those catheters as an infection, which is no longer categorized. And that's what this graph shows us. That the 60 and 70 that we talked about, which was a lot, that did include all CAUTI, which did have yeast in that definition. But if you take yeast out, that's when you got to 40. We still made a significant improvement from 40 down to, which ended up being 8. It was 5 in the 6 months. And again, this is an example of how CMS looks at this and what is their current threshold for CAUTI through 18. So the SIR of 1 was the number of infections that was equal to what was predicted, but their threshold was much lower than that. That was what was predicted, but if you were going to try to get points from this system, you wanted to have a lower number. And the number was 0.464 when this graph was made in 2018, but you can see that at that time we had very low at 0.233 and 0.331. So that was very positive. We actually had great achievement in working on a process, getting our number really low, and that certainly would have been an incentive potential for this, this indicator in the domain for safety. So you can see med-surg, they did an excellent job at Holston Valley with eliminating CAUTI, and they actually went for extended months without any kind of infection in the CAUTIs, and they were pretty tickled about that. The critical care units, of course, had to continue to work at that. We did a lot of things for them as well, but they needed to continue to work on that. So just to summarize what we did a lot of work in a short period of time. We had some really, really great results. And we actually went to 0 CAUTI in our med-surg unit. So I apologize. 0 CAUTI for upwards of 26 consecutive months through May of 2018 in the med-surg units, which was phenomenal. And we were really proud of that team. So, and then we did some celebrations, and we posted our thank yous on the units. We posted it in the cafeteria to recognize our nurses. And as Valid became in February of 2018, we did some more celebration, because that's when we hit the 26 months for that. So again, that's just an example potentially of some of the quality work that we do and the incentives of why we do that. And I just wanted to present that. I appreciate your time today. I know I talked pretty quickly. I was trying to do a lot of slides in a short period of time, but I'd be happy to answer any questions if you have any.